Hello and welcome to Surgical Insights with Dr.Deepz. Today I will be briefly discussing about hypokalemia and hyperkalemia. These are the two common but potentially life-threatening potassium disorder. So first I would be briefing with definition everyone has to know. So I would be activating my pen here. Okay. So here hypokalemia that refers to uh, potassium less than 3.5, while hyperkalemia that refers to potassium greater than 5 milliequal per liter. We have to know this. And definitely when the potassium in the body is low actually, and at that time potassium moves out of the cell to the blood. Okay. And potassium becomes rising. Okay. So this is the reason because intracellular potassium is 92%, 98%, and extracellular potassium is okay. Extracellular potassium is 2% of the entire body. We have to know this. So whenever there is a hypokalemia, the potassium moves out of the cell and comes to blood. Whenever there is hyperkalemia, the potassium oppositely moves inside the cell. Okay, this is what we need to understand. This is the physiology of nature. Okay, we need to know few more important thing in physiology. The role of potassium in the body and factors affecting serum calcium. So just wait a minute. First thing, maintains cardiac function. Okay, muscular contraction and nerve impulse transmission helps in nerve conduction and neurotransmitter release. And there is also acid and base fluid imbalance, helps normal pH and osmolality and fluid balance. Okay, enzyme activation and protein synthesis. Yeah, cofactor for many enzymes and protein synthesis. It is. So next thing, these are the most important in most of the examination. They may ask you like a question like all are important factors affecting serum potassium except, okay, for instance, increase serum potassium except, and they will give you the option for decrease. And similarly, decrease serum potassium except, they will give you the option for increase. So we have to know decrease renal excretion, which is kidney failure, acidosis, yeah, everything else, yeah, okay. And we need to know shift of potassium from intracellular to extracellular. In acidotic side, it decreases. So again, what it happened? Uh, the potassium release from cell to extracellular space and becomes sometimes it becomes hyperkalemia. We have to know this. And next thing, cell lysis and hypoosmolarity and excess intake and potassium supplement. Yeah, these are the thing that increases potassium hyperkalemia. Potassium sparing drug like spironolactone, ACI, A or B, and NSAIDs, heparin, etc. So we have to know most commonly examiner love to ask spironolactone as first question where it acts. You have to know collecting tubule, distal collecting tubule, okay, and you have to know collecting duct actually. And next thing they may ask you like gynecomastia. They may ask you gynecomastia. This question is confirmed. This both are confirmed. Okay. And yeah, again, heparin, they may ask you more. Heparin causes hyperkalemia. This also they will be asking in blood transfusion. Hyperkalemia may result. So this also they may ask you. Factors that decreases serum potassium due to increased renal loss and diuretics and hyperaldosteronism. Remember one thing. Here we can see hypoaldosteronism. And here we see hyperaldosteronism. Hypoaldosteronism usually increases potassium, and hyperaldosteronism actually decreases potassium. under ROS. Okay, under RAA. Yes, you have to know this. And in this slide, I will be also teaching ROS pathway, which is important physiology pathway. So yeah. One of the another reason is gastrointestinal loss, which may be due to acidosis and alkalosis. Vomiting may be related to alkalosis, and diarrhea, acidosis, and laxative abuse. You need to know. And next is shift of potassium from extracellular to intracellular. And insulin. This may be due to insulin beta 2 agonist alkalosis. And also one of the reason here in hyperkalemia, excessive intakes like banana and other potassium supplements. Okay, and here low intake or poor intake, we have to know. And other factors we need to rule out magnesium, because for hyperkalemia, magnesium increases, and for hypocalcemia and hypokalemia, magnesium deficiency happens. So there will be a increased potassium loss. Okay, increase renal potassium loss, and aldosteronism, potassium excretion, as I discussed here now. Okay, and other factors like glucose insulin imbalance and insulin deficiency, that may tends to increase potassium. Okay, that may tends to increase potassium. Okay, so here I'm discussing about aldosteronism pathway, or AAS, renin angiotensin system pathway. You have to know. So remember one thing, race A is that. So renin comes from actually angiotensin liver. Okay, angiotensin that enters the kidney and blocked by renin inhibitor. Okay, okay, and renin releases from kidney juxtajugular cell. You have to know. Here, what it happens is while releasing, because of blood pressure decrease, sodium decrease, and sympathetic stimulation, okay, may lead to JG cell to release potassium. This thing, renin converts angiotensinogen to angiotensin 1. Actually, in simple, I would be adding angiotensinogen. So there is a renin substrate added here. Renin comes from juxtaglomerular cells and converts into and makes convert angiotensinogen to angiotensin 1. And again, angiotensin 1 is converted to angiotensin 2 under the influence of ACE. Remember renin and ACE, that's all, easiest way. And ACE2 is responsible for vasoconstriction, that increases blood pressure, and sympathetic activity increases, stimulating aldosterone, and aldosterone is released. Okay, aldosterone from adrenal cortex. Okay, so aldosterone increase means potassium will decrease and leads to hypokalemia. This is what you need to understand. Main mechanism is potassium is decreased secretion of potassium. So may lead to hypokalemia, and increased secretion of aldosterone may lead to decrease potassium, hypo, and vice versa. You need to remember. Okay, and here as a result, blood pressure will increase, blood volume also will increase, and maintains electrolyte balance, and thus net effect is BP and volume increase. Okay, so you have to know, very easy if you understand it. So next is action potential. You need to remember this mnemonics. So R for resting. Okay, resting. So potassium permeability here keeps the membrane negative here in resting phase, negative potassium. And next thing is depolarization, where sodium opens. Actually, sodium opens here. Okay, depolarization. Sodium is open first, and under repolarization. Okay, under depolarization, sodium influx happens, that makes membrane potential increase. Okay, that makes membrane potential increase, and again it becomes repolarization and sharply sodium channel inactivates and potassium channel here opens. Potassium channel opens and finally potassium efflects and membrane potential falls here. Falls here. Hmm? Falls. After hyperpolarization, potassium channel closes slowly. Okay, closes slowly. Okay, potassium channel and becomes more negative in resting membrane potential. Okay, and this is what you need to follow. You need to know this by important and returns to RMP resting membrane potential and by potassium here closes and NA pump leak channel restore resting potential or for resting D for depolarization and or EP for repolarization and A for after hyperpolarization and returns to RMP. You have to know all the things and here sodium in to win and potassium out to settle. Yeah. So depolarization and repolarization after hyperpolarization you have to know. So potassium efflux causes repolarization and after hyperpolarization returning membrane to its negative potential. You have to know. And next thing, medications that affects potassium. So this everyone has to memorize. It is very important. Like insulin, beta agonist, sodium bicarbonate, loop thiazide diuretics by breaking NAK to Cl. Okay, there is a clinical problem in this. Thing. Okay, potassium binder. This is usually given along with this thing water to decrease potassium actually. So potassium binder. Next is cisplatin and amphotericin B and piperacillin. This is a broad spectrum antibiotic used in emergency situation for treating in surgical ward patient. Okay, and next is uh, lenalidomide. Okay, lenalidomide and abitronate, okay, abiraterone and phenodopam, digoxin, lactulose and albumopan. Okay, these are the factors that decreases potassium. Drug that decreases potassium and drug that increases potassium is ACE inhibitor and ARB, angiorenin blocker, and NSAIDs also that increase potassium, spironolactone and eplerenone, amiloride and triametron, okay, and SGLT2, okay, this also increases 2I, CNI tacrolimus and cyclosporin, this also actually increases trimethoprim, azoles also increases, beta blockers, heparin, succinylcholine and potassium supplement. This also increases. For here you have to increase potassium because decrease hypovolemia you need to increase potassium supplement and for increasing medicine that increases potassium you have to stop potassium supplement. Okay, always review the medication in hypo or hyperkalemia. Stopping or adjusting the culprit drug can correct potassium level. And before proceeding to this thing, we need to know one more thing that for all the potassium or calcium, we need to monitor patient with magnesium, and we need to give them correct the magnesium and then think about potassium or calcium. Okay, you need to remember. So ECG, most probably they will ask you to ECG, not the all. So flattened T wave they will be asking, and mostly they will be asking U wave and prolonged QT. That's all. This two they may ask you. Now ST depression is seen in ischemic injury, so they won't be confusing you. They will be asking flattened T wave in hypokalemia as well as U wave or prolonged QT interval. They may ask you. And next is for hyperkalemia, they may ask you tall T wave, tall peaked T wave in ECG finding, tall peaked T wave in ECG finding, or else they may ask you uh, wide QRS, wide QRS, okay, Q or yes, wide QRS. Okay, and very lab like exam, they may ask you sine wave pattern, sine wave pattern. Okay. Okay, so you have to remember the pattern of this thing, and ECG. They won't ask you ECG in this thing, which lead you may find this ECG, and they will straight away give you the clinical scenario on examination. Potassium value is decreased, and what ECG you can be finding in hypokalemia. So flattened T wave mostly, or U wave is most common. U wave is most common, along with prolonged QT is rarely or just you need to see U wave. And similarly for hyperkalemia, potassium level increased and they will ask you tall T. And wide QRS is rarely asked, very rarely asked, but asked. Okay, so you need to remember. And the key point for hypokalemia, delayed repolarization, prolonged QT, and risk of ventricular arrhythmia. This they may ask you, ventricular arrhythmia with torsades. This both they may. Torsades also presents in hypocalcemia. You have to know. And here again, increased potassium may be due to early repolarization change, then conduction defect. And here they will be asking sine wave, risk of cardiac arrest. And other than sine wave, they will be asking you only tall T. Or rarely they may ask you wide QRS, but most frequently they will ask you tall T wave. Okay. Before proceeding to hypokalemia, we would be discussing about this thing. There is a mild, moderate, and severe degree of severity in both hypokalemia and hyperkalemia. So hypokalemia, you have to think 3 to 3.4 mild. Okay, here you may be mostly giving oral supplement of potassium based on the mild, and in moderate also oral supplement of potassium with ECG monitoring you would be doing. Most rarely IV potassium chloride is needed, but in severe IV potassium is urgently required. Mostly patient will be given like potassium K bind, actually potassium bind. It's a powder given with water, plain water, as a juice or a protein shake we have to drink. Okay, and moderate is 2.5 to 2.9 milli equal per liter, and severe is lesser than 2.5 to 2.5 milli equal per liter. We have to know, or it is arrhythmia. This is very danger, and always check and correct magnesium before proceeding to hypokalemia or hyperkalemia, both of them. You have to correct magnesium. Okay, and in hyperkalemia, you have to stop intake with potassium intake. You have to stop and treat the underlying causes. You have to correct magnesium first. And mild cases like 5.1 to 5.5. And moderate is 5.6 to 6.5 milli equal per liter. Your main aim for hyperkalemia is remove potassium from the body. Remove potassium and make it to normal, not in hypokalemia state. And severe cases, you may be administering your patient with, after magnesium correction, calcium gluconate. Okay, protect the heart. And insulin plus dextrose shift potassium inside cell. Okay, and next is salbutamol beta 2 agonist, and remove potassium with using diuretics and binders and dialysis. Here, this I wanted to tell you. Usually diuretics, what happens is NAK2Cl transporter. Actually, diuretics will break this transporter. That's why potassium is decreased. By inhibiting the transporter NAK2Cl, potassium is obviously decreased. Okay, and you have to check it. Again, hypomagnesemia can worsen hyperkalemia. Again, you have to check the hypomagnesemia. Okay, so this is what you have to think. And the rest of all are, these are the mnemonics. Have done heart shift shaft. Okay, heart protection calcium is administered. Okay, and shift the potassium inside using insulin and salbutamol, and remove the potassium, diuretics, binder, dialysis. Okay, flush the potassium. That's all. Hmm? So question number 1, 72-year-old woman is admitted to the acute surgical unit with profuse vomiting. Okay, admission shows Na is sodium is 120, 131. 131 is decreased actually, but okay, not too much. And potassium is 2.2, urea is 3.1, and creatinine 56. Glucose is 4.3, which is decreased. Okay, which of the following ECG features is most likely to be seen? With the potassium profile 2.2, it is actually severe hypokalemia. So obviously U wave is seen. U wave seen. So again, this is the important physiology MRCS question, highest composition of potassium seen in saliva, like 60%. And rest of all, it is seen in 5 to 10%. Okay, and after saliva in duodenum 30 percentage, you have to know, and in saliva highest, you have to know this three, very easy. And next thing here, tall peaked T wave. Tall peaked T wave means you have to think about hyperkalemia. That's all, easiest one. And yeah, 45-year-old women with a history of bulimia nervosa and presence with fatigue and muscle cramp, and she admits daily self-introduced vomiting for the past 6 months. Okay, her ECG shows sinus tachycardia and prominent U wave. U wave. So U wave means actually U means it is hypo. It is down hypo, and T it is up tall T wave. So this is hyper. This is the way I remember. Okay. Okay. So U wave is actually hypokalemia. You have to remember. This is a interesting case, and you have to know the initial management. You have to know. In most of the question, you need to remember the. You need to read the questions carefully. Sometimes they may ask you initial step management, and sometimes they will be asking you appropriate management. What is the appropriate management? What is the first step management? So you have to read the questions very carefully. Here, 58-year-old woman with a history of Crohn's disease and the short bowel syndrome is admitted with profound weakness of fatigue and profuse diarrhea, watery diarrhea for 5 days. Okay, medication include loperamide and a proton pump inhibitor. Okay, results like Na sodium is 135. Okay, and potassium is decreased. Chloride is okay. Okay, and next is HCO3 is also decreased. Here, think about acidosis. Watery diarrhea already indicated is acidosis, and HCO3 is also acidosis, and potassium is decreased. Okay, so think about this, and magnesium also decreased. Okay, so here magnesium is decreased. So what will you do with the first step of management? Administer intravenous magnesium sulfate 2 gram over 10 minutes, and then you have to proceed to this thing potassium chloride to 20 millimole per hour. Okay. Second thing you have to proceed with a first always D. You have to think about. Okay. Next, we are going to read a 65-year-old man with a end-stage renal disease. Okay, on hemodialysis, presents to emergency department after missing his last two dialysis. Okay, he complains of nausea, vomiting, nausea, weakness and palpitation. Sorry, not vomiting, weakness and palpitation. He has been taking over the counter magnesium containing antacid and dyspepsia. Okay, please mark magnesium containing. Okay, blood result shows sodium is increased and potassium is elevated actually. 7.2 is very severe, and magnesium also increased here. Okay, magnesium also increased. So ECG shows peaked T wave and widen QRS. Okay, widen QRS. So you have to know what is the appropriate, most appropriate, immediate management, immediate management, this one only. Okay, so IV gluconate 10 ml with 10% of solution over 2 to 3 minutes, but actually it is supposed to be 10 minutes. I was very confused with this after seeing 2 to 3 minutes. Okay, it is supposed to be 10 minutes. And next is 72-year-old man is admitted with a acute heart failure exacerbation, and he has a history of hypertension and chronic kidney disease, stage 3. eGFR is 45 ml per minute, and his medication include lisinopril and furosemide 80 mg. Okay, and twice daily on admission. His blood result shows sodium 138 millimole and potassium is decreased. Actually, magnesium is also decreased here. Okay, and creatine is 130 millimole. Okay, so which of the following is most likely cause of this electrolyte abnormality? So answer is furosemide, axon NAK2Cl transporter. Okay, transporter, and inhibits potassium. So that's why it is hypokalemia, results in hypokalemia. Okay, so they may ask you based on ECG and management, and this both confirmedly they may ask you, and very minor with diuretics drug, how it acts. And coming back to potassium sparing, they will ask you where does at which site of kidney does the uh, potassium sparing diuretics act. Okay, and it causes gynecomastia. You have to know such a thing, basic thing you have to know. And definitely they will be asking more about RAAS system rather than this thing, definition of potassium. Always definition of potassium is more understood in clinical problem, but when it comes to physiology they will ask RAAS. Okay, and potassium, another thing we have to know, increase too much of potassium is actually threatening and may lead to cardiac arrest. This is the entire summary. Okay, hopefully you enjoyed the session. Thanks for watching. If you found this video helpful, please like, share and leave your comment below for the doubt and queries. And don't forget to subscribe to my channel to see upcoming videos on hyponatremia and other important medical topics. Okay, bye. Yeah.